So it's really a pleasure to spend a little time with you this afternoon to talk about metastatic bone disease. What do we know? And it's an important topic, and it's obviously not a topic that is foremost for endocrine consultation. You'll have a lot more cases clearly related to diabetes or specific neuroendocrine manifestations or other calcium or osteoporosis cases. However, it does really fit into the whole network of what goes on in bone and calcium, and so it's helpful for us to talk about it a little bit. And I want to keep this interactive, so if you have questions as you go along, please don't hesitate to jump in at that particular stage. So if we could just start over here, and this is your first week of the preceptorship, right? So you're sort of getting comfortable with everything and learning a little bit more about bone, but by the end of next week, this will all be old hat to you. But really, the skeletal manifestations of neoplasia center around focal osteolysis and focal osteogenesis. And more on the periphery, you have osteomalacia, with decreased phosphate, and I'm sure you're aware of and have probably seen the odd case of a low phosphate contributing to osteomalacia, and also increased calcium and osteopenia. And tumors can actually manifest a bone phenotype that crosses the spectrum, but is more predominant osteolysis or osteogenesis. And when you look at the tumors that actually cause metastases to bone, you can group them roughly into osteolytic and osteoblastic, although for the most part, they don't respect this definition entirely, such that a tumor can manifest both an osteolytic and an osteogenic component to it. Sorry, can you see? Probably with the exception of one, and that's, and we'll come to multiple myeloma as we go along. And the common tumors that metastasize to bone, or at least, when I was a medical student or perhaps a young resident or whatever, were like the thyroid, breast, lung, prostate. You've got a number of them that are just really osteotropic that seek to hide in bone. And as you'll see over here, some of them manifest both osteolytic and osteoblastic. So breast and lung typically can be osteolytic, and the importance of this distinction is the Cree cell that's responsible for the phenotype. So for osteolytic destruction, it's really the osteoclast that is revved up and doing its work, okay? But when it comes to osteoblastic, which is typically for prostate, but you can get breast as well, you get bone formation as a predominant manifestation, and that's mediated by the osteoblast. So if I can just point out at the moment over here, if you look at the skull, you see punched out lesions or osteolytic lesions. And when you look at this lateral view of the spine, you see one of the vertebrae over here that's actually a lot more opaque than the others, and that is a osteosclerotic phenotype. A typical picture actually in years gone by for diagnosis of multiple myeloma was a skull film, because of the lytic lesions that's actually so unique to that particular neoplasm. Now, if we just take a moment to look at what goes on at a cellular level, and we'll just look at this as osteolysis primarily. So I think you're probably aware already, if you look at bone over there, you see two osteoclasts on the surface of bone, and as you know, that bone is a tightly coupled organ where you have osteolysis, you have bone resorption and you have bone formation that are occurring constantly and in a sequence. However, there's a temporal distinction between the two such that the osteolytic component is a shorter period of time than coming back in after the osteoclast resorbs bone. The osteoblast comes back in and refills that bone. So that's the dynamic reconstitution of bone. And the osteoblastic activity actually takes longer than the osteolytic activity. So while the one is on the order of weeks, the other is on the order of months. So all we're trying to illustrate on this particular slide, and you have some osteoclast precursors, you have the mature osteoclasts over there, it's resorbing bone, and when it's doing this, it's liberating TGF-beta. And one of the considerations is that TGF-beta will then bind to the cell, a malignant cell, which will, through second messengers, release PTHrP, which you're well aware of. Every time you've got somebody with cancer with hypercalcemia, or you first check the PTH, and of course PTH is low, then you've got to start thinking of other causes. But anyway, PTHrP, which is instrumental in getting osteoblasts to do their thing, and then you have an increase in rank ligand, and a decrease in osteoprotegerin or OPG, and basically you set the cycle in motion for more osteoclasts to do their job. We'll keep rank ligand in mind because, from a therapeutic standpoint, we need to reflect on that a little bit later on. By contrast, just to get to the other part of the story over here, in terms of osteoblastic metastases, once again, of course, you've got the tumor cell, you've got PTHrP, some inactive fragments, you get proteases that are released, you've got the IGF binding protein complex with IGF, you've got FGFs, BMPs, and endothelin, etc. All of these target bone and set the osteoblast into motion to refill the excavated pit that the osteoclast has already created. Any questions before I go on? Okay. So what you have is a pattern where these two, bone in general is coupled, as you well know, but you've also got two parts of the cycle ongoing with the tumor cell involved in them. And you've got PTHrP release, you've got the osteoclast resorbing bone, the release of TGF-beta, and you get a vicious cycle ongoing from an osteolytic standpoint. And similarly, you get stuff going on in the bone microenvironment from an osteoblastic standpoint to set things in motion and to fill out the resorbed bone. Remember that the bone marrow is an ideal place for a tumor cell to go. There's turnover. As you know, you get, you're probably well aware that when you look at trabecular bone versus cortical bone, there are different turnover rates, such that looking at the spine, you get quite rich turnover, whereas you look at the hip, which has got trabecular bone, but it's also got cortical bone. Certain sites are more rich in cortical bone, and it takes a longer period of time to turn over. In other words, trabecular bone is more metabolically active than cortical bone. So if you're going to look at bone loss and you want to look at it with a shorter possible period of time, within reason with your technique, whether it's DEXA or whatever, the spine's the place to go because of the fact that it's more trabecular bone. Cortical bone will follow as well. You will see changes at the hip and elsewhere, but you just have to bear it in mind in terms of the biological pathway. So just to give a little bit of information about metastatic bone disease, the bone provides a perfect environment, the soil for solid tumor growth and progression. It's probably the third most common site for tumor metastases. You can think of other ones that are pretty common, the liver, etc. But the bone is right up there. And there are at least 250,000 cases accounting for 100,000 deaths per year from metastatic bone disease. The common tumors are breast, prostate, recognizing those are the two most common tumors in women and men respectively, of course, aside from the skin neoplasia that is not actually quite as metastatic as these. Lung, renal cell, pancreatic, colon, gastric, thyroid, and ovarian. The predominant target for the cells to go to, the tumor cells, is the red bone marrow of the axial skeleton, which we just spoke about, which includes ribs, vertebrae, and proximal long bones. So, it's not uncommon for somebody to have a rib metastasis or a spinal metastasis from tumor. And there's extensive osteolysis that's clearly mediated by osteoclasts. Any questions? Okay. So how do skeletal complications of bone metastases manifest? Well, an obvious one is bone pain. You get called to see a patient who's got bone pain. You image just with a straight film X-ray, and you find a metastasis. You can have impaired mobility, clearly related to the pain or other. Pathological fractures, just giving you a sense from breast cancer, it can be up to 40%. Spinal cord compression, which is of course a neurosurgical emergency. Hypercalcemia, getting back to the point of calcium. Osteoporosis and osteomalacia. These obviously aren't the common manifestations of metastatic bone disease, but getting back to our slide earlier on, when you gave you the spectrum, you can see these manifestations. It's important to think about these particular manifestations because obviously they're clinically overt, and when of course you wish to study metastatic bone disease to find out if you can do anything about them, you have to use an aggregate cluster of these particular manifestations to get a clinical endpoint to change that would be meaningful. Breast cancer, clearly the leading cause of death in women. Up to about 200,000 cases of invasive breast CA, and then of course it does occur in men as well. Clearly not that frequent, but as endocrinologists you're well aware of the fact of gynecomastia and other manifestations that you have to be on the lookout for in men too. Skeletal metastases occur in about 75% of patients with advanced breast cancer, and a third of the initial sites of relapse are actually in the skeleton as well. And the most common, it's actually the most common site for a first distal recurrence. And the median survival for patients with bone metastases is under 2 years. And I just did want to touch on prostate cancer at the same time. Clearly the second most common cause of cancer-related deaths. Patients, many patients with prostate cancer have metastases at the time that they do die, unfortunately. Almost 200,000 cases per year, and about almost 10% distal metastases at the time of diagnosis, and the 5-year survival rate is 33%. Getting back to the phenotype again, osteosclerotic metastases due to also increased bone resorption are the most common, and the median survival is just shy of 3 years in men with metastatic bone disease. So, when you think about the clinical manifestations of metastatic bone disease, I went through the whole lot of them, pain, etc., etc. It's important to lay them all out, and these data were some of the earlier trials that were done to approve therapies to treat patients with metastatic bone disease. And the common manifestations are pain, pathological fractures, including radiation to bone, as well as orthopedic manipulation, surgery to bone, spinal cord compression with nerve compression, hypercalcemia of malignancy, and and the pathological fractures, radiation, surgery, and spinal cord compression actually make up what we call a skeletal-related event. Okay, it's not that pain is important. Of course, it is. It's a very challenging part of managing this disorder. But if you look at all the objective criteria that you can readily measure without taking that into account, skeletal-related events are what we have. The original therapies, just going back quite some time, before there were inroads into treating metastatic bone disease, focused on hypercalcemia of malignancy. Okay, so what are the treatment options for patients with metastatic bone disease? Of course, they're the traditional approaches that have been used over the years, including radiotherapy, radionuclide approaches, endocrine treatment. Of course, for patients with metastatic prostate cancer, you use GnRH analogs such as Lupron and other anti-androgens. Patients with with breast cancer, you use anti-estrogens and anti-androgens as well. Chemotherapy, orthopedic intervention, analgesics, and of course there are other approaches in addition. So the current therapies that are indicated for metastatic bone disease fall into two classes: the bisphosphonates and then the rank ligand antibodies. Okay, so the bisphosphonates, I mean, you all use bisphosphonates pretty readily to treat patients with osteoporosis. Drugs like alendronate, risedronate, ibandronate, zeledronate, etc. Similarly, it's the same mechanism that's used to treat patients with metastatic bone disease. So originally, pamidronate was approved for breast cancer, multiple myeloma, as well as hypercalcemia of malignancy. And then zeledronate followed pamidronate and was actually approved for breast, prostate, lung, solid tumors, as well as multiple myeloma and hypercalcemia of malignancy. A little bit after the approval of those two bisphosphonates, the rank ligand antibody denosumab came along, and also approved much in a similar way for the solid tumors, breast, prostate, as well as multiple myeloma. And those are the cornerstones of the therapeutic armamentarium today for metastatic bone disease. Any questions? Okay. So what is the rationale for use of bisphosphonates in skeletal metastases? So remember that the tumor cell gets released, it's in the bloodstream, gets into the bone marrow, and these tumor cells are really sharp. They know how to bind to bone and actually take advantage of some of the receptors and second messenger pathways that bone resorption takes advantage of. And so there's cell adhesion, there's colonization, so and then they inhibit osteolysis, and you can they also reduce tumor growth in the skeleton. So the net result is that the bisphosphonates make the bone marrow less receptive or more hostile to tumor deposits. Okay, and there are different mechanisms over here by which they manage to accomplish that. So in some of the original trials that were done, I had mentioned pamidronate had been approved way earlier, and then zeledronate came along. And you know, when there's an approved agent, it becomes you can't exactly do placebo-controlled trials in this type of setting, given the risk-benefit for patients. And so the trials for zeledronate were done where zeledronate was picked actually on a number of doses, but firstly the 4 milligram dose versus the pamidronate 90 milligrams. The trial size was around 287 patients, and the entry criteria that you had to have a corrected serum calcium of greater than 12 milligrams per deciliter. Endpoints were the proportion of patients with a clinical response, and it's defined over there that, you know, with a serum calcium of less than 10.8 at a point of after 10 days of treatment. And there were other criteria as well, mean time to relapse, etc. And in this particular instance, zoledronate, which is a little more potent than permidronate, actually showed a response of 88% versus 70%, so it was quite superior, and that the relapse time for hypercalcemia of malignancy was prolonged to 30 days from what it had been previously of 17 days. So I'm going into a little bit of the details of some of these trials, not in excruciating detail, just because as endocrinologists, this isn't the bread and butter of what we see, but these mechanisms and therapies are what you use pretty readily in the treatment of other osteoporotic conditions, certainly. And then, basically the phase 3 trials for zoledronate actually included one active comparator trial and 2 placebo control trials. So remember I said permidronate was originally approved for multiple myeloma, breast and prostate, but not for all other tumors. So based on that, trials were being able to be done with an active comparator permidronate, and then placebo-controlled trials as well, because there was no standard of care. And now we're not talking about hypercalcemia of malignancy, we're talking about metastatic bone disease due to solid tumors. And the primary endpoint were the proportion of patients having at least one skeletal-related event, which we had defined previously. And then secondary endpoints were the time to the first skeletal-related event, skeletal morbidity, a particular endpoint that was defined, as well as a multiple event analysis. And the breast cancer and multiple myeloma studies were double-blind, double-dummy studies. The multiple myeloma patients were stage 3 with at least one osteolytic lesion. The breast cancer was stage 4 breast cancer with at least one bone lesion. Anti-neoplastic therapy was permitted at baseline and throughout this particular studies, ECOG performance status as stated, and they had to have a serum creatinine of less than 3 milligrams per deciliter, recognizing, the use of bisphosphonates in people with impaired renal function. And there were 12-month dosing regimens. Permidronate was given in a schema of every 3 to 4 weeks for 2 hours as an infusion. Zoledronate, and this is pretty interesting, there were 2 doses that were used. There was a 4 milligram dose and an 8 milligram dose, which was subsequently reduced to 4 milligram dose, and I'll come to that in a moment. Also, every 3 to 4 weeks, it was initially a 5-minute bolus push, and then that was amended to a 15-minute infusion. Study duration was on the order of 13 months, and all patients were actually given calcium and vitamin D supplementation, much as you would do when you're treating patients with osteoporosis, always making sure that they're having sufficient calcium intake and vitamin D. The point about this was that the dose originally included 4 and 8. The 8 was reduced to 4, and the infusion time was lengthened from 5 to 15 minutes because of the drug was not well tolerated in the patients, and related to some of the some renal insufficiency in addition. So basically, for breast and cancer and multiple myeloma, the mean age of patients was around 60 years. Clearly, a lot more women than men, because we're putting breast and myeloma together over here. And these were reasonably sized studies, about 550 or so patients per arm of treatment. And of course, giving you a sense of patients permitted to take chemotherapy and hormonal therapy as well. So on the backdrop of standard of care. And this is how the trials were constructed, and this is in a non-inferiority design. So the intent over here was you're going against an active comparator. You didn't pre-specify superiority. You were looking for non-inferiority. And the 4 milligram, that zoledronate, 4 milligrams, and pamidronate were pretty much comparable, with a 95% confidence interval showing that they were pretty much comparable. This is just to give you a little bit more breakdown of the components of the skeletal-related event in patients. Looking at all fractures, those patients who received radiation therapy, surgery, and of course, spinal cord compression, those who had spinal cord compression. And basically what you can see over here is there's no real difference in therapy. You might say by, just looking at each subcategory, perhaps the zoledronate 4 milligrams did a little bit better in some, but generally these were pretty comparable. And this is looking at the secondary endpoint of the morbidity. Okay, so I did also want to point out, because remember we started off talking about lytic and blastic lesions, and you're saying, like, why do we have to bother with this stuff? Well, it's just how they manifest. But the bottom line is, it's helpful to have the therapeutic trials and to drill into them a little bit. There's no real difference in how these bisphosphonates work, whether you have a lytic or blastic lesion. Don't get caught up on it. You have metastatic bone disease, treat with therapies that you can, and and see you see no real difference with the zoledronate versus pamidronate. And so this is just laying it out in a different format, looking at skeletal-related event, time to the first skeletal-related event, the skeletal morbidity rate, etc., as well as the secondary endpoint, multiple event analysis. Now, it's clear that oncologists are pretty much treating patients with cancer, and this gets handled in the oncology outpatient setting because they run infusion centers and they treat that. But as endocrinologists, you can be called to see a patient, and and it's important to be aware of this. So I wanted to step back for a moment and talk about denosumab, which I'm sure that you're all well aware of for the treatment of osteoporosis, which is the rank ligand antibody. Remember when we had the prior slide, we showed that with osteoblast metastases in the tumor cell, you have an increase in rank ligand and a decrease in OPG, or osteoprotegerin. So that favors a scenario that denosumab, the rank ligand antibody, may be utilized in the setting of metastatic bone disease, in addition to what it had been used, obviously, for the treatment of osteoporosis. So these trials were done by Amgen, who are the innovators of that particular agent, and the last one actually that we dealt with in terms of the drugs, those are Novartis drugs. The pivotal denosumab studies were 3 active comparator trials. So remember, by this point in the sequence of when the therapies became available, the zoledronate studies were complete, so you couldn't necessarily do placebo-controlled trials anymore. The primary analysis, once again, was a first on study skeletal-related event, a non-inferiority, and then they also had secondary analysis, the first on studies SRE, time to first and subsequent, and multiple event analysis, much as we had seen in the other trials. The dosing regimens for these clinical trials, starting with the breast cancer trial, was denosumab 120, given as a subcutaneous injection, and zoledronate 4 milligrams every 4 weeks, 15-minute infusion, because that is the dose after the changes that they made. Study duration now was up to 3 years almost, and patients all received calcium and vitamin D supplementation, pretty standard. Double dummy, active control, as we just laid out. Patients had to be 18 years or older. adenocarcinoma with at least one metastasis. ECOG performance status was similar. Creatinine clearance needed to be north or at least 30 mils per minute. So if you look at what's going on over here, and so I want to just point out one thing as you understand and look at these different trials is, remember when we started with the hypercalcemia of malignancy, we were talking about 247 patients or whatever it may be. And then we went into the active control, the studies with Zeledronate, and they were about 550 or so patients per arm. Now we're talking about 1,000 patients or so per arm, just given how, looking at the endpoint and the difference over here for non-inferiority. Mean age previously we had looked at was around 60, it's a little bit less than that, similar about also 56 to 57. Of course, most female breast cancer trial. Chemotherapy and hormonal therapy were permitted as per standard of care. And when you look at the time to the first skeletal related event, you actually see over here about 0.82, and the median time was actually not reached for denosumab and was for Zeledronate. So it basically showed in this particular study denosumab was superior to Zeledronate in delaying the time to that first skeletal related event. And then, there were other advanced cancer studies, excluding breast and prostate, and we'll come back to prostate. Same dosing regimen, denosumab 120, Zeledronate 4, almost 3 years, everyone getting calcium and D, and very similar entry criteria. And then in the advanced trials, they're almost 900 patients per arm. Median age was about 60, a little bit north of 50 for men, 60% or so. Chemotherapy, hormonal therapy, and just giving you the relative other tumor types, including multiple myeloma. And once again, over here in this particular study, the median, you get the time to the first skeletal related event, median time in terms of months, and the test therapy, in this case, denosumab, was not inferior to Zeledronate in delaying time to the first skeletal related event. Yes, please.
How frequent is the denosumab?
I believe in those trials that it may have been, I don't know if it was 3 or 6 monthly. I'd have to go back and look at that, but it was more frequent than it is for osteoporosis. And I think it was quarterly.
Okay.
So apologies for that, not putting it on the slide. And then in prostate cancer, once again, patients with documented bone metastases, a rise in PSA. These were men who were in the castrate range of 50 nanograms per deciliter serum testosterone. So they were already on GnRH analog therapy. No strong opiate analgesics, serum creatinine value, and then performance status, and of course standard anti-neoplastic therapy. They were stratified whether they had the presence or absence of distant metastases at the initial diagnosis. All patients, of course, getting calcium and D, and Zeledronate. These are the Zeledronate trials where there were 2 arms and placebo at that point, because this is where pomidronate hadn't been approved. This got down-dosed, this got lengthened the infusion period, and that was given 3 weekly, and there was a 15-month follow-up. And essentially what you saw here, and once again, let's look at the trial size, because it's a placebo-controlled trial, so the effect size you could tease out. And these men were a little bit older than the women, age of 70, you just get a sense of the baseline criteria. The important aspect of this is, and I can't explain the middle, but I will come to it in a moment, is the zoledronate versus placebo did decrease skeletal-related events. So 4 milligrams was significant when compared to placebo, and this didn't capture fractures necessarily, right? And it's funny enough, when you look at the 8 milligram dose that was reduced to 4 milligram dose, it didn't come out as being statistically significant, but numerically it was trending in that direction, showing that the bisphosphonate therapy did make a difference to these particular patients. Now, when you look at the combined analyses, when you pooled the actual data and look at patients with skeletal-related events, once again, zoledronate was superior to, was statistically significant. And of course, when you break it up against X-ray therapy, radiation, all fractures, as spinal cord compression, surgery, etc., you just see a trend in in certain instances, statistical difference of that the bisphosphonates zoledronate was superior, was significant when compared to placebo by month 15. And this was the secondary endpoint that we had spoken about previously, the skeletal mobility rate. Now, when you look at the prostate cancer trial and laying it out over here, time to the first skeletal-related event, the SMR and the multiple event analysis, once again, you really see robust data with the bisphosphonate mechanism in affecting the key endpoint in patients with prostate cancer. So it decreases skeletal complications in men with prostate cancer. I do for a moment want to, my apologies, monthly. So I knew it was more frequently, but I just didn't realize it was that frequent. Interesting. In prostate cancer trial design, so subsequent to zoledronate, we learned about the evaluation of, once again, denosumab, the rank ligand antibody, and of course now they'll have to be active comparator trials, so they're going to be much larger trials, but the stratification, presence or absence of distant Mets at time of initial diagnosis, everyone gets calcium and D. The comparator was zoledronate 4 milligrams IV Q4 weeks versus denosumab 120 sub-Q Q4 weeks and for more than a year. And essentially, you can see that the sample size is obviously a lot larger because you're going for an active comparator study over here. Mean age was similar. Of course, they're all men, and it's giving you the ECOG performance status, ethnicity, and baseline PSA as well. And when you look at zoledronate versus denosumab, you're talking about time to first skeletal-related events, about 17.1 months versus 20.7 months. So the test agent, the new agent at that time being denosumab, decreased skeletal complications in men with prostate cancer and actually was superior when compared to the standard of care at that time, zoledronate. So those are the pivotal trials that have been done out there for agents in treating metastatic bone disease. There are other agents that one may consider for metastatic bone disease as well. Well, we've already touched on the bisphosphonates, but it doesn't preclude additional work by aminobisphosphonates because they're highly effective. Alpha V beta 3 integrin antagonists. The alpha V beta 3 receptor allows the osteoclast to attach itself to bone. Okay, this receptor sees a motif, the RGD motif, and allows an attachment to bone. So the question is, well, if you have an antagonist of that particular integrin receptor, etc., dimeric protein, perhaps you can interrupt bone turnover as well. So in a period gone by, there have been tests with integrin antagonists to see if you can interrupt that binding. And in patients with osteoporosis, you were able to actually demonstrate with integrin antagonists an increase in bone mineral density and a decrease in the turnover markers, okay, the resorption markers. Bless you. So similarly, these agents have been tested in metastatic bone disease, but the trials were much smaller and they were just like hypothesis generating, such that if you use these agents, will you decrease bone turnover markers, you know, NTX, CTX, etc., those markers that you're learning about over the next week or so. And the key part of this is both breast cancer cells and prostate cancer cells express the integrin, the alpha V beta 3. And remember, we said that the osteoclast attaches to the bone through these integrins. The hypothesis is that the tumor cells attach to the bone in a similar way, and that's how they get their toehold. No one's done a really a real clinical trial looking at metastatic bone disease with a key outcome measure, but the hypothesis stands. The question is, are these mechanisms potent enough to compete against bisphosphonates and rank ligand antibodies, or to be paired with them? The other target that I want to mention just for a moment are cathepsin K inhibitors. So cathepsin K is a cysteine protease that, so remember in bone, and I can't draw because remember in bone you've got your calcium hydroxy, your calcium phosphate and your hydroxyapatite, etc. And you need to do two things. You need to create an acidic microenvironment so you can really demineralize the bone. Okay, so you open up that calcium phosphate, that scaffold, and you expose the collagen, type 1 collagen, which then gets digested. So the cathepsins actually digest the collagen. Cathepsin K digests type 1 collagen, of which the bone is comprised of at least 90% plus. So the question is, okay, so these molecules actually work in inhibiting bone resorption, and they increase bone mineral density, they decrease markers of bone turnover. So the question once again is, do these inhibitors have a part to play in the treatment of metastatic bone disease? Because once again, the tumors, breast and prostate, express cathepsin K, and that may be a way that they get into bone and take advantage of it. Those trials have not been done, but it's just from a hypothesis generating standpoint something that you can consider. And of course there are other mechanisms that folks have considered. I think that's the final slide at this point, and I'm happy to entertain any questions that you may have. Yes.
So for these bisphosphonates and for the denosumab, do you have any trial information about decreasing bone pain?
I don't know the data on bone pain. They weren't reported as a key outcome in the literature distillation of these. But if one goes into the FOI, the Freedom of Information, where you can find all the information that was filed with regulatory authorities such as the FDA, in those particular packages you may find that information, or people may have questioned that at the time the molecules were approved following an advisory committee. There's probably information there, but I don't know that offhand. That's an excellent question. Thank you. Yes, go ahead.
Do any of these trials address, I guess, like the less common subtypes? Like, I assume you, for hormonal treatment, you talked about prostate adenocarcinoma.
Yeah.
You came across a couple patients with, like, small cell, where it probably originated there.
Small cell in terms of lung or neuroendocrine small?
Yes.
Okay.
Well, which is the same. It's lung. It's either from I've then had to read about it, so pulmonary or extrapulmonary. But yeah, like small cell carcinoma or neuroendocrine cancer that go into bone.
So some of those trials captured some tumors, I assume, that weren't necessarily adenocarcinomas, unless it was an exclusion and they had to have phenotyped the tumor exquisitely, which often doesn't happen. And so my assumption is some of those are probably captured in there, but there may be too few to numerically cull out to see if there's a separate effect. But I can't answer that with confidence.
Okay. And Gautreaux is a particular patient who's also producing PTHRP, so hypercalcemia of malignancy, and also had lytic lesions.
And how did you treat the patient?
So bisphosphonates didn't seem to do much.
So you first did hydration.
Oh yeah,
all that standard stuff. Did you use calcitonin?
Yeah. Probably for a day or two.
And then so bisphosphonates like zeledronate didn't do much.
Unfortunately, we actually have trouble getting zeledronate, but pamidronate didn't do too much, and then denosumab was very effective, and we got hypocalcemic for a little while.
So you were able to counter that with oral calcium?
Yes. Mm-hmm. Yeah, the malignancy was advancing, so he was a little bit complicated, but just from that side of things, so I'm curious.
Yeah.
Yeah, so I can't comment on, how many tumors are of a neuroendocrine background versus typical adenocarcinomas in these studies. But I'm sure you could call up or ask somebody who works at these places. Any other questions? Or Emery, you got one for me? No? Okay. Great. Okay, well, thank you very much. I really appreciate it. I know this is not a typical endocrine talk. Maybe it would have a different emphasis if it came from an oncologist. I don't know. But I think it's important to think that what you treat osteoporosis with, which predominantly endocrinologists, rheumatologists, primary care physicians, continue to treat. Some of those therapies have a lot of overlap with therapies that are used by oncologists to treat patients with metastatic bone disease, albeit the dose and the regimen will perhaps differ because you don't want to overtreat in osteoporosis such that you become hypocalcemic or that you get bone that's not turning over to reconstitute itself. But this is a troubling condition, and it's good to be aware of where things fit in the therapeutic paradigm. Great. Well, good luck with the rest of your time here, and hope you enjoy and learn a lot. Thanks.
Thank you.